Assalamu alaikum, the long clinical consultation day. First scenario, a 36-year-old lady who presented with palpitation and weight loss. Observation showed the heart rate of 100 beats per minute, otherwise normal. Please take history and examine the patient and address her concerns. Ready, Dr. Mina?
Yes, sir.
Okay, here you go.
Hello.
Oh, hello.
I'm Dr. Akbar. I'm one of the doctors in the clinic today. May I confirm your name and age, please?
I'm Sally. I'm 36.
Miss Sally, I'm here to discuss regarding your health condition. For that, I'll be taking your history and doing your examination. Is it fine with you?
Yes.
So, can you tell me that what has brought you in the clinic today?
So for the last few months, I've been feeling heart racing, and it's actually affecting me the whole day. And I've noted that I've lost weight as well.
I'm sorry to hear about this, and I'll try to address this. Uh, can you tell me about your racing and pacing first? That how it started, suddenly or gradually?
I think a bit more of a gradually. I started to feel it particularly during the night time, and I just feel the pulsation in my head because of that. And it's
Oh,
kind of there most of the time.
mhm. If I ask you to tap, so can you tell me that it's regular or irregular?
I'm not sure, sorry.
Okay, is it fast, right?
Yeah, it is very fast.
And you said that most of the time you have this in a day, right?
Yes.
And do you get it daily?
Yes.
Okay. And may I know that is it the first time you are having this problem in this few months?
Yeah.
Okay. Anything you notice that makes it better, like a good sleep, a good mood, and when you eat something?
No, not really. No.
Okay. Anything that makes it worse, like when you exert or at the end of the day, and like when you are anxious, have you noticed?
I think I recognize it more towards the evening and during the night time. But I think this is because I am busy most of the time during the daytime. So I get really
Mhm.
distracted.
Okay. How's your sleep?
Not very well because of that.
Okay. And how's your mood these days for past few months?
I think I was right.
Okay. May I know that have you noticed any rise in body temperature?
No, not really.
Are you being tired during this time period?
Yeah, I feel very tired and I feel hot when other people feeling cold.
Okay. And if I know about the tiredness, like is it like the whole day or any particular time of the day?
No, most of the time.
Okay. Any weather preferences?
Pardon?
Weather preferences, like you like hot or cold?
Weather. I prefer colder weather.
Okay. And can you tell me that you said that you lost weight? How much and how long?
I've lost a stone in the last 3 months. Thank you.
Okay. And it's unintentional?
No, yeah, unintentional. I tried to eat, but I'm not picking up my weight.
Okay. And how's your appetite?
My appetite is really good. I'm trying to compensate, but I don't feel
Hmm.
that I am regaining the weight that I've lost.
Okay. And has anyone told you you are being pale these days?
Pale.
Yes.
No.
Okay. And how is your diet? Do you take a healthy diet?
Yeah, most of the times, yeah.
Okay. Any hunger pangs?
Pardon?
Like any hunger pangs? Do you feel like any cravings for food happened, like hunger
No,
pangs?
no, 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 no.
Okay. Any loss of consciousness during this time period?
No, no.
Any headaches?
Oh yeah, occasionally, more often in the last few months actually, yeah.
So does the headache remains all the time or does it comes and goes?
I think comes and goes.
Okay. And what type of a headache is it? Like throbbing, dull type?
I think kind of throbbing, kind of pain, particularly when I'm feeling the palpitations.
Okay. Any particular time of the day you have the headache? Like it's a morning headache or an evening headache?
No, no, no. Any time of the day, it does not matter.
If 1 being the least and 10 being the highest, how will you mark the intensity of headache?
I would say like 4 or 5 out of 10.
Okay. Do you feel like throwing up during the headache?
No,
Okay. Any vision problems?
no.
Any abnormal shakiness of your hands or any part of the body?
Yeah, I think I think, but I attributed that to anxiety actually. But yeah, I've noted that I'm shaking most of the
Mm-hmm.
times. Yeah.
Okay, all right. And have you noticed any sweating of your like palms or any part of your body?
I think I'm sweating more than usual, yes.
Okay, all right. Any weakness in any part of your body?
Weakness, no.
Any dizziness while you stand up from sitting
No.
position? Okay. Any balance problem?
No, not really.
Okay. May I ask you any tummy aches?
Me, you ask, sorry, what?
Tummy pain? Any tummy
Tummy
pain?
pain. No, tummy pain, no.
Okay. Any problem in your bowel works, being hard or loose?
I think looser than usual.
Okay, all right. And is it for how long?
For the last couple of months, actually. Yeah.
Okay. Is it watery or bulky?
O të lekësore.
Sorry?
Aveciye, rakën.
Sorry?
It's watery, yeah.
Okay, all right. Okay. Any joint pain?
No,
Any skin changes, like any skin rash, any skin pigmentation,
no,
any cough,
no,
any difficulty in breathing,
no,
any flushing of your skin?
no,
Okay. May I know, is there any long-term illnesses you would like to tell me?
no,
Any history of hospitalization or surgeries?
no. I've just had a cesarean section a couple of years ago, and that's it.
Okay. And any over-the-counter medications, any painkillers, any herbal medications, anything?
I just take paracetamol every now and then, particularly for the headaches.
How often you take it?
I take like 2 tablets twice or 3 times a day when needed, but not regularly.
Okay, all right. Any chest pain?
No,
Any leg swelling?
no.
Any gasping of air while you lie down?
Any?
Any air hunger? Air hunger
No,
when you lie down?
no.
Okay, may I ask you a few personal questions?
Yeah, of course.
Any similar complaints in the family?
No,
Any cancers in the family? Sorry to ask you.
no,
Any sudden deaths in the family?
no,
Do you smoke?
no,
And any alcohol?
no,
Sorry to ask you, any party drugs?
no.
Okay, how are your periods?
Quite irregular actually for the last 4 months.
Irregular. Are they
Yeah.
heavy or scanty?
I think they're more heavier, on the heavier side.
Okay. Any chance you are taking any birth control pills?
No, and I'm not pregnant.
Okay, and any history of baby losses or miscarriages?
No,
Okay. May I know that how are this? What do you do for a living?
I'm a nurse.
Okay, and how are the symptoms affecting your daily life and workplace?
I think at some point I felt the work is distracting me from the palpitations, but overall I became more tired and fatigued, and the frequent bowel motions is draining me. So I needed to take some time off from work actually.
I can understand your concern, and I'll try to figure it out what's happening with you. If you need any help, we can make a medical report for you. You can discuss it with an occupational health officer at your workplace as well. And in case of any social support, we'll provide you as well. Is it fine with you?
Yeah, please.
Okay. May I know that do you drive?
Sorry?
Do you drive?
I do drive, yes.
Okay. Have you experienced any problem like while driving, any dizziness,
No, not
any
really. No,
any loss of consciousness?
no.
Okay, all right. So I would like to examine the patient.
Yeah.
So I'll start my examination first by observing the patient from the bed end for a few seconds. And I would like to offer for the vitals, specifically the blood pressures, the pulses. And I'll see the hands of this patient first, any signs of anemia, any sweaty palms. I would like to ask her to outstretch her hands and fingers so I can see and appreciate any fine tremors.
Can
I
I
would
can I
like to
give you
feel.
some findings?
Okay.
So the patient looks over low body mass index,
Mm-hmm.
fine tremor bilaterally
Mm-hmm.
and symmetrically in both hands. Um, heart
Mm-hmm.
rate of 110 beat per minute,
Regular.
regular. Yeah, blood pressure
Okay.
normal. No flapping tremor.
Okay. Okay. So then I would like to check the face of this patient. Eyes for any anemia, jaundice.
No anemia, no
Ma Okay. Mouth for any anemia, jaundice.
no mouth
Okay.
for cyanosis, no cyanosis.
Okay. I would like to check for the visual acuity in this patient and offer for the fundoscope as well. And I
You
would
can
like.
do visual acuity.
Okay. Okay. Is it fine?
It is alright. Yes,
Okay.
fundoscopy is good.
Okay. And I would like to check the JVP and for any carotid bruit as well, and any uh, swelling in the neck, any neck swelling or anything I can appreciate in the neck.
Is it inspection or palpation?
First infection, then palpation, then I'll
So
feel for it.
okay, so JVB is normal, no lymphadenopathy,
Any
um,
thyroid swelling,
no obvious thyroid swelling.
no obvious thyroid swelling.
Mm.
Okay, all right. I'll feel for that by asking to take a sip, then I'll feel and then I'll check for any movements. And then I would like to palpate the abdomen in this patient as well for any bilateral masses.
I'm
I
sorry,
would
can we
like,
go back to the neck? So you
sorry,
ask, sorry, can we go back to the neck? So
okay,
you want me to have a sip of water and you palpate in
yes.
the thyroid.
Mm,
Could you
mm.
explain that in more detail so I can give you the findings?
Okay, I'll ask the patient to take a sip
Mm-hmm.
and I'll check for the movement. Then I'll again ask the patient to take a sip and hold till I feel the swelling or anything I can appreciate with my fingers, and then I'll ask the patient to then swallow the sip of water, and then I'll feel that I can feel any swallowing if it's moving
You
and
could feel
touching
a
my fingers.
homogeneous swelling that's affecting
Mm-hmm,
both lobes of the thyroid gland.
mm-hmm,
It is not tender.
mm-hmm.
It is smooth surface. And
Okay.
what else you trying to find? I'll tell you.
Okay. I'll check for the thyroid bruit, and then I would like to focus for the retrosternal extension of the gland as well.
So percussion note is resonant and no pre heard.
Okay, all right. And okay, then I would like to check the abdomen for any palatable masses in the abdomen. I would like to check for the renal bruit as well.
No, negative, negative.
Okay, or any tenderness in the abdomen as well.
No, fine.
2 minutes left.
Okay, okay, and then I would like to offer for the urine dip in this patient, and I would like to check for the reflexes, any reflexes in the knees, and that's it.
Hyperreflexia, both knees, read knee jerks.
Okay, so what are your concerns, Miss Ali?
I'm not sure what's wrong with me. I'm not sure.
Mm-hmm,
Is it something that we can treat? Is it something serious?
mm-hmm. So after taking a history and doing your examination, it seems that there is a gland in front of our neck. I believe that it's over functioning, and that is why you are having the similar symptoms of these racing and pacing of your heart, the
Mm-hmm.
weight loss, and the other symptoms you are experiencing. What we'll do that I'd like to do more tests in form of some blood test as well and some scans of your neck as well, and we'll
Mm-hmm.
discuss further management plan with you.
Is it something that we can treat?
Yes, as we have uh, I have addressed the complaint timely. We will like to start you on some medications and then we'll
Mhm.
follow you up. So it's quite manageable.
Thank you.
Okay.
Anything else you want to ask? The history?
Sir, me?
Yes. You're having female with the, as you said, thyroid, right? Anything else you can ask to rule it out? Any association?
Mm.
Okay, you
Female
have
history, sir.
not only female history, I mean something related to the thyroid or association with thyroid in young female. Okay, time is up. Almost there. So you can start, Dr. Ines, the questions.
I think the overall approach was really good. She asked most the
No,
question that I
the
expect.
question. Sorry, examine the question first before comment.
Oh, so I need to question her. Okay.
Yeah.
Okay. So could you please present the case and give me 3 top differential diagnoses for this case?
So I have taken the history from this 36 years old young female with no significant past medical history of note. She has weight loss in last few months, which is unintentional, and with history of palpitations as well for last few months, getting worse with time. And she has also given me history of some on and off headaches with some sweating of the palms as well. Associated with there are some symptoms of diarrhea for last few months as well, followed with there's a history, no significant family history of note in the patient. Other than that, on examination, there are fine tremors positive. Heart rate is 100 beats per minute, regular, and there is a thyroid swelling, which is moving with the deglutition as well. And other than that, there is hyperreflexia bilaterally in the knees. And these are the findings on examination. So, keeping this in mind, I would like to keep hyperthyroidism or thyrotoxicosis as my first differential. I would like to keep pheochromocytoma as well in one of the differentials as well. And I would like to keep celiac disease as well in one of the differential as well. And that's it.
Okay, and how would you manage this patient? What, if to start with, what investigations you'd like to send for her?
So I would like to do baseline investigations like complete blood count, renal function tests, including the electrolytes in this patient. I would like to go for a complete thyroid profile in this patient as well, followed with ultrasound neck and radio iodine scan in this patient as well. I would like to go for a 24-hour urinary catecholamines or metanephrines for few and maybe G scan as well. I would like to do for a complete urine routine examination as well in this patient. And also, I would like to go for stool analysis for culture and cytology as well. And other than that, I would like to go for anti-TTG antibodies if I'm thinking for celiac disease as well. And management will be in form of education, counseling, explanation, making a multidisciplinary team, which will include a physician and endocrinologist, specialized nurses. And I would like to manage my patient by starting on replacement for thyroxine replacement as well. And for other than that, I will treat the patient accordingly with underlying causes.
You did mention that you're going to start managing the patient with thyroxine replacement. How would that work if the patient has hyperthyroidism?
Like anti-thyroid medications.
Antithyroid medications.
Yes,
Okay. Could you
yes,
please tell
yeah.
me more about these antithyroid medications?
Yes, we can start patient with symptom management. Like we can start patient with beta block, like propranolol can be given for symptomatic management. We can start patient with carbimazole and propionathiolol accordingly. And that's it. We can also see that, yes, accordingly.
What would you counsel the patient about if you're about to start carbimazole?
I will counsel the patient that with these medications, patient can have signs of neutropenia, any form of sore throats, then she has to inform us any weight gains, any allergies and rashes. Then I would like to counsel the patient, educate about these side effects of the medications,
And
and
if the
inform
patient
us.
is considering pregnancy in the near future, would
Mhm.
you guide her to do to take any of these medications over the other?
So we will like switch on the medications in that way that we can give patients in the first trimester. We can start patient on propiothyroxine and then we can switch to carbamazole. In that way, we can like plan pregnancy, including a woman doctors, and then we can switch the medications according to the trimester.
Yeah, fantastic. And what is
Yeah.
if you're thinking of it as Graves' disease, what is the mainstay for treatment? Is it medical treatment or surgical treatment?
So for if it's a Graves disease, we can see that it will be depending that we can give a start patient on any radioiodine therapies as well. But then we have to see that patient if the patient is in like childbearing age, and we need to see the factors for that as well. If patient is a candidate, then we can plan as well, and not then we can see for any medical options. And other than that, we can plan for the surgical options definitely.
Okay. And you did mention that you're going to do thyroid function test. Could you please expand on this a bit?
So we can do thyroid profile in form of like T3, T4, TSH. Other than that, I would like to go for anti-thyroid stimulating antibodies in this patient as well, anti-thyroglobulin stimulating antibodies, and also we can go for anti-TPO antibodies as well in this patient.
And if you found that the patient, it's not a Graves' disease, but when you've done an ultrasound of the neck, you found one nodule, how would you go forward if you found a single nodule? How would you investigate this further?
Like I said that we can go for an ultrasound, then we can go for a radioiodine isotope scan uptake for as well, that it's a hot nodule or if it's a cold nodule, then we can plan accordingly that if we need to go for an FNAC, then it will be after the radioiodine scan, we can plan that.
Okay, fantastic. Thank you very much.
Yeah, thank you.
Okay, one question for me, please, Dr. Minam. What is the cause of this hyperthyroid state?
Um, Sir, it could be it could be a possibility that itself is a primary cause, and it could be related with any other associations as well.
So give me the example and the differential.
So it could be a primary thyroid disease in the patient itself, and other than that, it could be a part of any cluster as well. Like it could be a part of you can say autoimmune polyglandular can be there as well. It could be autoimmune thyroiditis, including celiac, Addison's, pernicious. That could be there. It could be with MEN2A as well, with pheochromocytoma and with hyperparathyroidism. And other than that, it could be with any thyroid could be there as well.
Okay, and the top of them, what do you call it?
Sorry, sir.
On the top of your differential, what you call it? Thyroid hyperthyroidism
So
in the female.
thyrotoxicosis, yeah.
Yeah,
Ji.
thyroid cause what the underlying cause?
Like you mean by in a cluster? What should I say that?
You mean autoimmune, right?
Autoimmune, yeah. Autoimmune, it's like autoimmune
Yeah.
cause.
So this is the top differential. What the
Yeah.
second differential in female?
Pheochromocytoma.
No, I'm talking about hyperthyroid state. What could be the second cause of hyperthyroid state in female in such age?
It could be secondary to any polyglandular syndrome could be a part of that as well.
To have
And
polyglandular, you have to have other manifestation of polyglandular.
yeah, it could be Graves as well itself.
Yeah, okay, Graves as autoimmune, right?
Yeah. Mm.
What other cause
A-
of thyroid, hyperthyroid state?
And it could be postpartum
Yeah,
thyroiditis as well.
this is what I
It
need to
could be,
mention. Yes,
yeah,
that's it.
and it could be decorvin thyroiditis if there is any recent
Yeah, this is the one also. The last
uh,
one will be what other cause of hyperthyroid?
Riddle's thyroiditis, anaplastic Riddle's thyroiditis can be one of the possibilities as well.
Okay, what else? The last? Any medication can cause hyperthyroid?
Medication induced.
Yeah, like what? Give me example.
Amiodarone induced.
Okay.
Mostly. Yeah.
Okay, that's enough. Thank you.
Yeah.
So,
Thank you, sir.
Doctor, yeah, thank you. You can comment now, Dr. Enough, then I will comment.
I think the overall approach was really good, and the examination was good. I would just need to add a few things that you could have asked about. I would ask about the hair loss. I would ask about any thinning of the skin. I would ask more about the eye symptoms like any double vision. And in terms of the examination, you've done most of the examination, but I would do more when I examine the eye. I will check for lid lag, lid retraction, exophthalmos, and I would do the cranial nerve examination 3, 4, and 6. I think you've mentioned that, but I would focus more on the eye symptoms. And when you went to the thyroid examination, it was good. You do like inspect, then you do active inspection by asking the patient to have a sip of water, and then you ask the patient to protrude the tongue out, so to see if the mass is thyroglossal cyst or not. Then you do the palpation and make sure that you look to the patient's face to see if there is any pain or not, of any tenderness, I mean, because that would be another differential diagnosis for tender thyroid gland. And you rightly said that you need to do the percussion and the auscultation as well. And you spotted that you need to do reflexes. I would also ask about the proximal weakness. You did ask about weakness in general, but I would give more directed questions about, do you have any problems combing your hair in the morning? Do you have any problems moving from seating position to standing position? And I would examine that for proximal myopathy in examination. Ask the patient to hug themselves and to move from sitting to standing, etc. So these are the things that I would like to add. And when you ask me, I found it a bit like you've been asking me about some signs that you might spot on examination. When you ask me in terms of the palpitation, is it regular or irregular? I'm not really sure if I ask my patient, they would able to spot this. But maybe people who have irregularities with the heart will be able to spot that. I'm not sure. And you ask me if people notice that I am pale or not. But these, I would look into that when I examine rather than asking the patient about these. But pretty much, I think you're very good with the management plan. But particularly if this is a thyroid case, when I mention, I would give most of my time exploring about the thyroid before I mention other differential diagnoses like pheochromocytoma or celiac disease, etc., etc. I would say this is a hyperthyroidism, and that could be because of Graves' disease or toxic multinodular goiter or toxic adenoma or an early stage of dequervian thyroiditis or postpartum thyroiditis, but the lady given birth 2 years ago, etc. And I would argue why this is not the case. So Graves' disease is my top differential diagnosis given by this. Toxic multinodular goiter is my second differential diagnosis, but it's less likely as the patient has had homogeneous thyroid gland. And toxic adenoma is less likely because I did appreciate a homogeneous big gland rather than a single nodules. And the Quervain thyroiditis is unlikely because it wasn't tender when I felt it. And drug-induced thyroiditis, the patient denied any medications in the past. Postpartum thyroiditis is unlikely to happen after 12 months after giving birth. And I would not, honestly, I would not focus much on the investigations about celiac and pheochromocytoma before I spend most of the time on the main diagnosis here, because otherwise you will waste your time speaking about investigation for celiac and pheochromocytoma and missing the main stuff for the thyroid disease. And I understand that everyone knows what is a thyroid function panel, but it's very important to say I'd like to take TSH, T3, T4, anti-TSH receptor antibodies, antithyroglobulin, etc. And the management, very good, like conservative, medical and surgical and medical, symptomatic, and working on the antithyroid medications. you spotted what needs to be what the patient needs to warrant about, like a granulocytosis and risk of infection. And I've had this question actually in one of the mocks about if the lady asked me that she's planning to get pregnant and what should I advise her in terms of the pregnancy medications. But overall, very well done, I would say.
Thank you, Dr. Yes, really, your comment is very valuable one and very fatty one. You commented on the old thyroid, hyperthyroid, almost of the mostly the gravis, as you said. I agree about all the comments. Dr. Mina went distracted regarding the diarrhea. She thought about celiac. Yes, could be association with autoimmune, but you have to rule out celiac by your questions. If you are saying celiac here, you have to have diarrhea related to the food, right? Certain type of foods. This is the first thing, and you couldn't say it in the differential because you have thyroid, hyperthyroid state. So what you have to do or to mention here as differential, as Dr. Inas said, the differential diagnosis of hyperthyroidism, not the differential with celiac pheochromocytoma. Okay, yeah, pheochromocytoma, you can say it, but after giving the most common cause of hyperthyroidism. In the top of them, graves. This is what I asked you earlier. And to have graves, you have to have examination of the eyes. You ask only for acuity. Dr. Inas remind you regarding the lid lag and exophthalmos, you have to and lid retraction, and you didn't do all of them. By the way, they will minus you in the clinical examination or identify the finding or physical examination. To say this is graves, you have to have goiter, you have to have eye finding, and the other manifestation of thyroid. Okay. Like palpitation or the AF might be there, the reflexes, hyperreflexia, and also the eye manifestation, as I said, plus the goiter. Okay. Back to the question. Whenever you have thyroid, you have to know the last delivery. Why? You could say this is postpartum one. You ask about pregnancy, but you didn't ask about previous delivery, right? I think so. So the last delivery, exactly when? If within 1 year, you can say this is postpartum one. That's why I'm asking you what's related to the thyroid in the female in this age. You have to know why and what you have. Why this patient is having thyroid? Is it autoimmune? Particularly with the female, with the family history, you can have that like this. So you might have family history of autoimmune. Then you can say this is, for example, autoimmune. And of course, to say this is decurvin or subacute thyroiditis, you have to have history of infection. I don't know if you ask about previous history of infection. In summary, thyroid disease is a very common topic in the cases. Be ready, you might have it in your diet, either first day, second day, or third day. Okay? Even on surrogate. Sometimes they bring surrogate, but because of the very important topic, they bring the topic itself, either as a patient or as a surrogate. You have to be ready to answer all the questions related to the hyperthyroidism as well as the hypothyroidism. Okay? The causes, as Dr. Inas mentioned, the hyperthyroidism, either gravis or multinodular or toxic nodule or adenoma, all of them. You cannot say here this is men, because I heard you saying men,
No,
right?
sir, I didn't say men. No, no,
You didn't
I
say men.
didn't mention. No, no,
What I hear,
I didn't.
men or maybe polyglandular. Okay. Okay, why not men, Dr. Minam?
Because sir, there was no family history was there also, and there were no other signs of hyperparathyroidism I could not rule out as well.
Only that? What do you think thyroid state in men?
Um, Patient will have medullary cancers like that
Oh,
form in the patient.
yeah, so it will be
Yeah,
euthyroid or hyperthyroid or
youth.
hypothyroid.
Yes,
Exactly.
sir.
So you don't have euthyroid. Sorry, you have
Mm.
euthyroid, you don't have hyperthyroid. So if to say this is men, you have to have only goiter, enlargement without thyroid or hyper or low or a hypothyroid,
Mm.
right? So cannot say this is a differential. You can say polyglandular, but again you have to have Addison as well as diabetes if possible. But don't mention men as a differential of thyroid. Okay, hyperthyroidism particular. I mean, not. But you can put it in goiter. Okay, I think Dr. Inas also covered the most important parts in the topic. I think I cannot add anything else. Yes, as she said, don't mention stool analysis here unless you have some infection possibility, travel history if you suspect. Plus, the thyroid itself as a specific investigation. You didn't mention the antibodies, which is very important here. Antithyroglobulin and anti-thyroid stimulating antibodies. You have to mention them rather than saying other investigation, as Dr. Inas mentioned. You have to be ready to mention all of them. Okay, what other antibody you can add if you have hypothyroidism?
Anti-TPO I mentioned, so.
Okay. Try to know the full name, antithyroid peroxidase antibody. If you don't have the time, you can say TPO, but better to mention the full name. Okay? Yeah, thank you, Dr. Minam. Well done, but still, the questions are disorganized. What I mean, you ask about the tummy pain, then chest pain. I wanted you, and you ask also any awakening overnight. I want to ask you the question in the same system while going from up to down. You got my point. So you don't ask question before this system before the other, unless you forget. So keep it at the end only.
Can I just add one small thing? I've just went through my notes
Yeah,
actually,
good.
the thyroid,
Continue.
and the only thing that was not covered that I did not mention it. It's always good to ask about neck mass symptoms, any stridor, any problems with the swallowing, any hoarseness of
Perfect.
the voice.
Yes, perfect. Okay, based on this, what is the importance of asking this question, Dr. Minam? Why I'm
Sir,
asking about, yeah,
I asked for the lumps and bumps because I cannot see the patient right now. So I don't
it's
know that
okay.
how much of
No,
the
no,
mass
her
is it.
point, no,
So,
Dr. Inas saying the symptoms itself, any
so
difficulty of swallowing,
so
difficulty of breathing. Okay,
that's because like if it's compressive symptoms are there, if the
okay,
mass is obstructing the patient, that is why for any recurrent laryngeal nerve compression or any
okay.
difficulty, so that is why these are red kind of a obstruction could be happening because of a large mass.
So what signify for that? Or what it
That's
can
for like
signify?
it can like you need to have a urgent surgical intervention to the patient.
Okay,
Patient requires,
perfect.
yeah.
Yes, you're right. So I'm asking this question to have an other indication for surgery. So it's important to ask any compression symptom there. I will ask you one last question before moving to the next scenario. What are the indication of surgery in hyperthyroidism?
Arrhythmias, one of the reason. Other could be diplopia and thyrotoxic periodic paralysis could be one of the reasons as well. And congestive cardiac failure and thyrotoxicosis or thyroidostrom could one or these all can be the reasons of admission in a patient with
No,
hyperthyroidism.
not admission. I'm saying surgery. When you do thyroidectomy, for example.
When the patient has compressive symptoms like any dysphagia, any difficulty in
Okay.
breathing, and any voice changes.
Okay, this is all as compression. What else? Failure of medical surgery, is it indication?
Yeah, like optimal medical therapy if
Okay,
it's
what
not improved.
else? Cancer and
Yeah.
cosmetic. If the patient saying she doesn't like, for example, is it it looks for hair as uncomfortable, right?
Hmm.
So you have to know all these things, the indication of surgery in hyperthyroid or goiter itself, not only hyperthyroid, any goiter.
Hmm.
Okay, thank you, Dr. Inas. Very nice preparation of the case, and also Dr. Minam, she got the case. But yeah, she has to work on the differential, not to put the other differential, which is not related to the case here. Okay, Dr. Minam? So whenever you have thyroid, you have to put the differential for hyperthyroid itself, not or they complain as diarrhea or whatever. You have it as a clear diagnosis now. So you can put the differential of hyperthyroidism rather than saying the celiac and fucocytoma. Yeah, fucocytoma, it makes sense actually. But you can put before that the all causes of hyperthyroidism. Okay, particularly if you have the headaches not related to or not comes in episodes, or there is no shaking, no anxiety, all the things going with the fucocytoma. So you can say against fucocytoma, I don't have this and that. Clear?
Yes,
So, okay, you can post your scenario for Dr. Ines.
I have posted already.
Yes, okay. 65 years old male with dropping things since 8 months. Prepare yourself, Dr. Ines, then I will come back to you. I will read the comment quickly. Initially, the differential, some doctors wrote the differential here as Dr. Victoria. Hyperthyroidism, she put it in, I think, the most correct differential, the top, then anemia, gastrointestinal malignancy, celiac disease with anemia again, and weight loss. Agreed. Fucocytoma, as I said, yes, it could be, but after saying the causes of hyperthyroidism. Dr. Mansour, anemia, anorexia nervosa, Addison, hyperthyroidism, diabetes. Why diabetes will cause tachycardia and palpitation. Autonomic, maybe autonomic neuropathy. Yes, okay, less common. Dr. Ihtisham, min to A, yes, again, if you have goiter without hyperthyroid state, you can mention min to A. Otherwise, you cannot say this is min to A. Dr. Kutuf, what is the case? Okay, we posted already. Has asked about family history. Dr. Hisham, yes, we stress on this point, why she should ask about family history. Dr. Dina, I am not sure if diabetes, sorry, or Dr. Minam asked about the red flags, pressure symptom. That's why Dr. Inas commented on. Difficulty in swallowing, short breath, any voice problem. Perfect. Dr. Ala, compression symptoms change line of treatment to main surgical, exactly. Cosmetic purpose as indication, yes, we mentioned it. Plus the cancer and failure of medical therapy. Whenever you're ready, Dr. Inas, let me know.
I'm ready.
Okay, here you go.
Oh, hello, my name's Ina. I'm one of the doctors here today. Can I confirm your name and your age, please?
My name is Ali and I'm 65 years old.
Aline.
Ali.
Ali. And okay, is it right to call you Ali?
Yes, doctor.
Okay, first of all, thank you so much for coming to see me today. How can I help you today?
So, doctor, I've been having some problem in my hands for last few months,
Mm-hmm,
and I'm not able to hold things in my hand.
mm-hmm. Is it because you feel that your hands are weak, or is it because your hands are shaking?
I feel that my hands are weak.
Okay, and is it both hands?
Yes, it started in my right hand, and then it's on my left hand as well.
Okay, and did you notice any weakness elsewhere?
Yes, doctor, I feel that there is some form of weakness in my hands.
Did you notice any weakness in your legs, for example?
No, doctor.
Is it more towards the end, is it the start of the day, or more towards the end of the day, or it does not matter?
No, doctor, I think it's all the time.
Okay, and how did it appear? All of a sudden or gradually?
Doctor, it's happening gradually.
Gradually, okay. And did you have any other symptoms with it?
Like,
For example, did you have any numbness or tingling sensation of the hands?
doctor, sometimes I do have this as well.
And tell me more about that. Where exactly you feel the tingling?
Doctor, in my hands.
Tingling in all of your hands?
Yes, doctor.
Okay, and do you feel like pins and needles?
No, you can say it's like tingling, but I cannot appreciate if it's pins and needles, but it's some form of numbness.
Okay. And any things that makes it worse or better?
Like,
Like any medication that makes it better? Any position that makes it worse?
doctor, I think that I have this numbness and tingling more when I try to do any activity, and I feel that it's more in the night as well.
Okay, okay. Could you tell me more about your gait? Did you notice any changes in your gait?
Mm, doctor, with age, I've become slow, but I have no problem in my gait or any walking problem.
Okay,
But I'm
okay. And you
mm,
feel that you have a stable gait, you did not have any falls?
no, doctor.
Okay. I'd like to ask you other questions and start from head to toe just to make sure that we're not missing anything. Is that all right?
Mm, yes, doctor.
Do you have any headache?
No.
Any dizziness?
Yes, doctor. Sometimes I do feel dizzy when I stand up from sitting position.
And for how long you've been feeling this way?
Mm, for a few years, you can say.
Okay. And did you have any incidents or any falls because of that?
No, doctor.
Okay, okay. Did you notice any eye changes or eye problems?
My eyesight is a little weak for a few years.
Okay. And do you use
So,
any eyeglasses?
no, doctor, but I don't drive.
Okay. Do you have any problems going down the stairs or reading a book?
No,
Okay, okay. Any chest pain?
no, doctor.
Okay. Any palpitation or heart racing?
No,
Any cough or phlegm?
no,
Any tummy pain?
no,
Any nausea or vomiting?
no,
Any change in the bowel habit, constipation or diarrhea?
no,
Okay, okay. Did you lose control of your bowel or bladder at all?
no.
Okay, okay. How was your mood recently?
My mood is fine, doctor.
Okay, and how was your sleeping overall?
It's good.
It's good. Okay, that's good. Okay, and do you have any past medical history for which you see your GP regularly for?
Doctor, I have diabetes for last 10 years.
Okay, and what do you take for your diabetes?
I'm on insulin and pH. It's 12 units in the morning and 10 units in the night.
And when was the
Also,
last? Oh, sorry.
and also I take dapagliflozin 5 mg daily.
Okay, and when was the last time you've had your HbA1c or the sugar level checked and with your GP?
Doctor, it was almost a year back.
And how was it? Do you remember?
It was 8.2.
8.2. Okay, okay, okay. And do you have any other medical issues?
Yes, doctor, I have a gland problem as well, and I take thyroxine for that.
Okay, and when was the last time? How much do you take for it?
Doctor, I take 50 microgram daily, but the visit was almost 6 to 7 months back.
Okay, and you haven't had a recent blood test to know how's the glands going?
No, doctor.
Okay, and do you have any other medical history?
No, doctor.
Any previous surgeries?
No.
Okay, okay. And any family history of any similar presentation?
No, doctor.
Okay. Do you smoke?
No, doctor.
Any alcohol?
No.
Okay, okay. And are you still working?
No, doctor. I'm a retired teacher.
And okay, retired teacher. Okay. And do you live on your own?
Yes, doctor. I live with my wife.
You live on your own.
With my wife.
You're with your wife. Okay. And
Yes, sir.
how independent you are at home?
Yes, doctor. I can manage myself quite well. But for last few months, I feel this problem in dropping things, and I don't know that why it's happening, and I feel difficult sometimes to hold a pen as well.
Okay.
So I'm not sure that what's happening with me.
I'm sorry. It must have been hard. We will have an idea when we end this consultation about why what might have triggered this, and hopefully we can find a solution for it.
Thank you,
So
doctor.
so are you able to go for a walk?
Yes, doctor.
Okay, and you didn't notice any change in your exercise or recently with these symptoms?
Doctor, my activities are almost the same for a few
Okay,
years, like, so I don't notice anything difference in my daily activities.
okay, okay. I'd like to ask you a few other questions if that's all right.
Yes, please.
Did you have any high temperatures?
No, doctor.
Any lumps or bumps anywhere?
No.
Do you feel sweaty or hot?
No, doctor.
Okay. Would you mind if I ask you, did you notice any this is a bit private, I'm sorry, but did you notice
Mm-hmm.
any problems in your sexual activity?
No, doctor, I didn't notice.
Okay. Okay. Would you mind if I can examine you?
Yes, doctor.
Okay. So I'll start by inspecting the patient, looking for the face, how is the facial expressions, and assessing the patient's tone. Is it monotonic or monophonic? If the patient has expressionless face, I'd like as well to ask the patient to walk for me a few steps, and if safe, to do the tandem gait and check for rompering test.
So the patient is normally looking aged in front of you, and he's normal looking, no facial changes. He's normally looking at you, and the gait is fine.
Okay. And what about the arm swinging both hands? Is it normal?
It's
Is
normal.
okay. Any tremor anywhere?
When you are seeing the patient, there are no resting tremors.
No resting tremors. Okay, that's fine. Okay. Now I'd like to ask the patient to put their hands in the front of them. I'd like to look to
Okay.
the hand if there is any nail changes, any abnormalities in the hands. I'd like to check for any. I'll check for the pulse. What is the volume,
Pulse.
the rate?
Okay. The hand shape is normal, and the pulses are regular, 75 beats per minute. No radial release, and volume is good.
Did you say regular or irregular?
Regular and no
Okay.
radial delays.
Okay. At this point, I'd like to check the blood pressure and check for blood glucose level.
Okay. Blood pressure is 120 over 80, and blood sugar levels are 100. They are normal as well.
Okay. Now I'd like to look to the eye, check if there's any signs of conjunctival pallor, jaundice, or xanthelasma or corneal ergus.
Negative.
I'd like to check the tongue if there is any central cyanosis.
Negative.
Okay, then I'd like to examine the upper limbs in particular. I'll start
Mm-hmm.
by inspecting the upper limbs, looking if there is any wasting, any deformities, any scars in the upper limb.
Negative.
I'd like to assess the tone of the upper limb at the elbow joint and the wrist and check if any clonus.
No clonus, and the tone is normal.
I'd like to check for a pronator drift to start with, and then I'd like to assess the strength of the upper limb. And I'd like to start by asking the patient to stretch their arms in front of them and close their eyes, looking for any pseudoathetosis. Then to ask them to flip their hands over and to close their eyes and check for any pronator drift.
No pronator rift.
Okay, and what about the muscle strength in the upper limb?
It's good.
Okay, now I'd like to assess the coordination by asking
Mhm.
for a finger to nose test bilaterally, looking for any dysmetria or pass pointing.
Patient can do it uh, without any pass pointing.
Okay, I'd like to ask the patient to do the dysdiadochokinesia, flipping the hands in each direction.
Okay, he can do it.
Okay, now I'd like to test the reflexes for the triceps, biceps, supinator, and the Hoffman signs.
Okay, present.
I'd like to
Hoffman negative.
Okay, I'd like to test for the sensation now for the pinprick, soft touch, proprioception, and vibration.
Okay. Sensations are lost up to the elbow in glove and stocking.
Okay, okay. At this point, I'd like to have a look to the fingers to check if there is any. Oh, yes, the patient is diabetic anyway. I'd like to do the same for the legs to see if any stocking distribution in the legs as well for the same sensation? Pinpricks,
Yes,
soft.
it's present.
Okay, okay. And it's present, it's okay, so it's positive. Okay. And we did at the start test for pinpricks and it was negative or positive, sorry.
Negative.
Okay. And when we test for the pronator, not the pronator drift, when we test for pseudoathetosis, was it positive or negative?
It was negative.
It was negative. Okay. Okay. Now I'd like to so mainly neurological examination that I'd like to do in general. And I'd like to do a cardiovascular examination quickly, listening if there is any murmurs, and I'd like to listen for a PROE over the carotid arteries as well.
Normal.
Okay. Okay. So, okay, now I'd like to explain. So, what is your main concern?
So, doctor, what is happening and how will you treat me?
Okay. So, so first of all, thank you so much for coming to see me today. From what you've mentioned, that you've been more
2 minutes
have
left.
that you've been having difficulties on holding things recently, and given your significant diabetes history and the few positive signs today on examination, I'm quite concerned that you might have complication from your diabetes that's affecting the nerves. And this is one of the common complications from diabetes, particularly if it was uncontrolled for such a long time. How does that sound to you?
Yes, doctor.
I think at this point, I'd like to get an up-to-date bloods, particularly looking for your blood glucose and what is the glucose storage in the body, just to make sure how is your diabetic control. And I'd like to examine the back of the eye as well, looking for any changes in the back of the eye that might correlate with everything going on. And it might be a good idea actually to refer you to the eye doctor if I found anything abnormal in my examination. And we need to better manage your diabetes, for which we need to I'd like to refer you to the endocrine or the diabetes nurse, who will be able to follow up with you. And I'd like to ask you, how do you normally monitor your blood glucose?
So, doctor, I usually forget to check my blood glucose. My wife check it most of the time with the glucometer.
And how often does she do that?
Twice or thrice a week.
Okay, and is it usually normal or high?
Uh, it's mostly around 150, 180.
And this is high or low? Or hello?
Yes, okay.
Yes.
Okay,
Yeah,
so
time
this is
was up.
high.
Yeah.
Okay.
Dr. Minam, you can start the question, please.
Okay, so according to the findings, what are your differential?
So this is a 69-year-old gentleman who has significant background of uncontrolled diabetes, and he presented with main presentation was dropping things. On examination, I did not appreciate any significant weakness. However, he did have sorry, I forgot. Okay, yeah, he did have gloves and stocking distribution of sensory loss for pinprick, soft touch, proprioception, and joint position that's affecting symmetrically the upper limbs up to the elbows and the lower limbs up to the knees. So my different top differential diagnosis for this gentleman uh, would be uh, would be sensory predominant peripheral, sensory predominant sensory motor peripheral neuropathy. And my top differential diagnosis for this is diabetes. However, other differential diagnoses for this includes other reasons. That would include uh, so other causes for sensory predominant sensory motor peripheral neuropathy includes metabolic causes like uremia. However, the patient did not have significant history that affecting the kidneys. Other differential diagnosis could be alcohol in neuropathy, which is unrelated here because the patient did not have any alcohol take. However, I did not dig into the previous history of alcohol in this patient. Other differential diagnosis for this could be paraneoplastic or drugs related like or vitamin deficiency, particularly B12, B6, and B1. And so treating this patient, I'd like to first of all take a set of observation and send a urine dip looking for any proteinuria or glucose, which is likely P positive. And I'd like to get a blood glucose reading and send for HbA1c. And as well as I'd like to get nerve conduction studies. I'm expecting that the patient would have length-dependent peripheral neuropathy, and that would be mainly axonal. And just to rule out other mimics, I might need to consider an MRI, but I do not think that's going to be very helpful in this situation. And it's very important, particularly with patients with complicated diabetes, to look for other complications, particularly looking for any diabetic retinopathy, because most patients with diabetic nephropathy and diabetic neuropathy would likely have diabetic retinopathy as well. I'd like to send as well a set of bloods. This would include a full blood count and urine function, LFTs and UNEs, to look for UNEs, particularly to look for any diabetic nephropathy. um, um, Managing this patient, it should be a multidisciplinary team that would involve an endocrinologist and a neurologist and a diabetic nurse as well. And that would involve educating the patient about the importance of diabetes management, and they would need strict glucose monitor, and they might need to upgrade their insulin, and it might be beneficial to get them a continuous glucose monitor and to teach them how to manage their insulin. And at this point, unfortunately, the diabetic nephropathy has developed. It's very important to manage it with medications for neuropathic pain like gabapentin or pregabalin. But we need to keep an eye as well on the kidney function, because these drugs might accumulate in patients with chronic kidney disease due to diabetes.
Okay.
Minam, any other question?
No, sir.
So the differential, Dr. Ines, what
Um,
are the differential?
So this is sensory predominant sensory motor peripheral neuropathy with gloves and stocking distribution. My top differential diagnosis for this case is diabetic peripheral neuropathy. However, other differential diagnoses includes metabolic reasons like uremia or vitamin deficiency B1, B6, B12, and folate deficiency, or toxins in a form of alcohol or other drugs that might cause peripheral neuropathy. And it could be paraneoplastic or infectious due to HIV, or it could be uh, uh, it could be as well paraproteinemia due to multiple myeloma or AMGAS. And this is the sensory predominant. The motor predominant, which is less likely in this case, could be due to lead poisoning or porphyria or Guillain-Barré syndrome, but these would, if they're typical, they would appear more of motor predominant rather than a sensory predominant.
Okay, what do you think drugs can cause peripheral neuropathy?
So carbcysteine, not a carbcysteine, is it carbcysteine? Pleomycin can cause peripheral neuropathy. Isoniazid can cause peripheral neuropathy. What else? I'm not sure. Sorry.
Okay, thank you, Dr. Nas. Well done. Let's hear the comment from Dr. Minam, then I will comment.
Okay, so you took a very nice history, and what I believe that few things I think about the weight you didn't ask me anything, and this patient has a weight gain as well for last few months, as well as I gave you a clue that the symptoms of numbness is more at the night. So he has a night pain as well. So you can go through more about the hand pain, how it gets better, and all the localized questions of the hand pain. So overall, your history was fine, and other questions. So this was a case of bilateral carpal tunnel syndrome, secondary to hypothyroidism, and you can keep and you have to check all median nerve assessment, the pincer grip, the hand grip, the Tinel sign, reverse prayer, and prayer sign in this patient. So you could correlate that. And you have to examine the thyroid gland as well in the patient. And other than that, you can keep CTS secondary to hypothyroidism. Polyneuropathy can be one of the differentials. You didn't ask me about my diet, I think, how the diet. So osteoarthritis is one of the differentials of hand pain and dropping things as well. And other differentials in the lower down with the age, dropping things. You can also keep Parkinson's as well, but you rule out the gait. And so these are the differential. So you can treat the patient for accordingly.
Actually, I've had a mental night of carpal tunnel when I was asking the history, and I kept that I need to examine for carpal tunnel, but I forgot that.
Yeah. So if you examine, so the clue is there. So
So what are the symptoms that the patient have that reflects hypothyroidism apart from the weight gain?
no symptoms. Like it depends. Like the patient is taking the medication properly or not. He told you that the visit
Oh, the
was 8
patient is
months
already
back.
hypothyroidism. Yeah.
Yeah. Thyroxine. So it would be a possibility that he was not taking the medications regularly. His
Yes.
old age, the visit was not well. You asked me for the levels, was not there. But weight gain was a clue, and it was there. And all the median of examination specifically was there. And that is it. So that you can go through that.
I think, to be fair, when I ask about the muscle power, and I ask about the muscle power in all the muscles of the hand, and you kept saying that it is normal. I think if I found that the muscle power in the thinner, for example, muscles is weak, I would have concentrated more in that area and
Now
examined both.
you have to ask me particularly for the palmar and dorsal interlacei, for the ulnar, for the pincer grips, and for the thumb adduction and abduction, and for the fifth phalanx specifically.
Oh, I see. I didn't realize that.
Yeah, and then for the radial nerve, wrist extension, wrist flexion, specifically for each dermatome. So that I can tell you that you have to ask me for each dermatome for each nerve.
Okay, thank you.
Yeah.
Okay, thank you, Dr. Raminam and Dr. Inas.
Yes.
What do you think the defect was there, Dr. Inas, in the history? The nature of the pain, the nature of the weakness, right? Did you
Well,
ask? Yeah. Is it electric like shock?
no, I didn't ask that. Yeah. To
So
be
this is,
honest, at some
yeah.
point, I didn't know what was the presenting complaint, why the patient is dropping things. Is it
Yeah,
like
you have to know in basis what are the most common cause of weakness in the hand. So let's revise. What do you think the most common cause of distal weakness? This is distal weakness, right? Hand weakness means distal weakness. What do you think in basis? What are the causes of distal weakness? Very common in basis. Give me the most common.
diabetic, peripheral
Diabetic,
neuropathy?
yeah, patient rather than having weakness, yes, it could be there, but he will tell you I have tingling or numbness, right?
Mm-hmm.
But you have weakness. How can you
So,
explain the weakness in basis? The most
see,
common causes.
unilateral causes like stroke.
Stroke will be like monoparesis, right? Not only the
Yes.
hands. Difficult to have hand. I am talking about distal weakness. Okay, you want to start with the unilateral. Okay, mention the unilateral, then we will mention the bilateral.
So unilateral could be due to stroke, tumor, demyelination, trauma.
Unilateral, including the distal and proximal. You
Mm.
specify the distal, okay? This patient is having distal weakness. You are
So this
talking
is
about, okay,
like mononeuritis multiplex,
okay, yeah,
carpal tunnel syndrome,
yes. So,
radiculopathy,
uh,
plexopathy.
like yesterday, myelopathy, right?
Yeah.
Sorry, myelopathy might be bilateral. However, it could be also unilateral. Continue. Yes, what else?
Um, I think nerve entrapment due to like any other reason.
Perfect. Yes, any trauma, any cast, compression over the nerve like ulnar or radial or median, all of them can cause that weakness, okay?
Yeah.
It depends, either wrist drop or claw hand, according to the nerve injury.
Mm-hmm.
Okay, what else? Unilateral. I think we covered most of the common cause of unilateral, right?
Mm-hmm.
Now we'll talk about bilateral. What do you think the cause of bilateral hand weakness or distal weakness in particular?
Are we thinking of metabolic causes like hypothyroidism?
Perfect. So you have to talk about systemic or something affecting both hands.
Yeah.
So what are the causes?
If it is more proximal, I would think about cushion. I would think about polymyalgia rheumatica.
By the way, paroxysmal myopathy, you have a lot of reason. You have to know them. As you said, rheumatological, endocrinological, even genetic, right?
Mhm.
But I'm talking, okay, we finished the proximal now. Give me the reasons or the cause of distal weakness. I give you a clue.
Hypothyroidism, metabolic, other non-metabolic causes.
Okay.
I'm not sure. I do not want to waste everyone's time. I'm not sure. Sorry.
No, it's okay. We are thinking. You have to think systematically. I said earlier, rheumatological, endocrinological, genetic. If this patient is young,
So it,
30s, yeah.
I think like vasculitic in a form of mononeuritis multiplex.
Okay, mononeuritis will be unilateral rather than being bilateral because
I
mono,
see.
one
I
nerve.
see.
Yeah. So what about bilateral? In
Um,
genetic causes, young patient.
oh yes. Oh yes, I know this. Wait.
Myotonica.
Yes,
Yes.
myotonic
See?
Myotonic
dystrophy.
Yeah,
dystrophy.
it will come, yes. So myotonia, type 1, one of the distal or causes of distal weakness. So you
And
might have it the
inclusion
weakness.
muscle and inclusion muscle myositis as
Yeah,
well.
we are talking about the common. In cases, myotonia, one of the cases, it might come
Yeah,
as a weakness.
yeah,
So you will get it from the family history,
yeah.
right? And particularly the patient will be young.
Mm-hmm. Yes.
Occasionally, rheumatological causes, right? Like rheumatoid arthritis, right?
But
So
you
what?
would expect to see some deformities before that, no?
Okay, how the hand will be weak in rheumatoid arthritis?
It would be like with certain deformities, like a Z-shaped deformity of the thumb, or swan neck, or Petrine
It
contraction.
wouldn't be weakness rather than deformed, right? So the function will be difficult to be done, but the
Mm-hmm.
power will be still there. Maybe because of the deformity he cannot do. But you have now weak. I'm talking about something complicated rheumatoid arthritis, which is our case today. Carpal tunnel, right?
Yes.
So in the top of your differential carpal tunnel syndrome, you should put it in your top differential. What
Okay.
are the causes? You have to know what the cause,
Mm-hmm.
particularly in the hand.
Mm-hmm.
Okay. I prefer to ask what type of weakness you have, either floppy or stiffy one.
I see. Okay.
Yeah. Why? Because the stiffy one, you will have different differential than the floppy one, right?
I see.
Okay. What other differential of carpal tunnel? Now we are talking about carpal tunnel, right?
Mm-hmm.
What do you think the other cause of carpal tunnel?
So other causes of carpal tunnel could be hypothyroidism or obesity related or Cushing syndrome that's causing hypertunnel. Or if it's a lady like a pregnancy or
Perfect. Yeah.
uh,
What else?
what
So
else?
you can put in the top or
Mm-hmm.
as a cause weight gain and put what are the cause of weight gain, right?
Sure. Yeah.
Plus some other physiological like pregnancy.
Mm-hmm.
Pregnancy also can lead to the carpal tunnel,
Mm-hmm.
and some occupational, some jobs can lead to carpal tunnel, right?
Yes, right. Oh, yeah.
Like vibration tools.
Mm-hmm.
That's why you have to ask about the nature of the weakness you have. And the timing you ask actually, but supposed to specify a question for if you know the case as a carpal tunnel, or you put it in your differential, you will ask what can relieve your pain or your weakness. She told you I have particularly pain at night.
Mm.
What do you think can increase, can improve the weakness or the electric activity?
I think a couple of reasons. In
No,
the
no.
night,
What can relieve it?
I
If,
think alleviating the arm or
yeah.
the.
What else?
Uh,
It's very important question you have to ask. Someone know from the chat box?
Sir, like shaking hands, gripping,
Exactly.
this
Yeah.
this can relieve. This is the most common thing
Exactly.
in
Yeah.
CTS.
Shaking hand is the question you have to ask to say this is carpal tunnel syndrome, and the patient will tell you yes, I have to shake my hand before sleep, for example, and the pain will be relieved.
I see. Okay.
Okay. What else you can see in the hand if you have carpal tunnel?
You'd expect to see sensory loss with the
Exactly. Yes.
three fingers and a half from the front and 2.5 from the back.
Yeah, and I think this is against our examination finding today. Suppose Dr. Minam will tell you he has sensory loss over the lateral part of his hand, 3.5 right finger or 3.5 finger,
Is it lateral or medial?
lateral one in the supination. Okay, so the thumb, the index, and middle finger, and half of the
Oh, yes, you're right.
fourth
Yeah.
finger.
Yeah.
Okay, these are the manifestation. And while tapping here, the patient will have pain.
Yes.
You mean I mean above the wrist. Okay.
Mm-hmm.
If there is maybe diabetic neuropathy covering the all hand sensation, I don't think it will be occasionally. Patient will have both of them.
Mm-hmm.
But I don't think also the blood sugar with 150 or hemoglobin A1C on number 8, the patient will have the manifestation of peripheral neuropathy.
8 is high, right? No.
Yeah, it's high, but you have to think about something else. Plus you didn't ask about the other complication of diabetes,
Oh, yes, I didn't.
the macro and micro, right? You didn't ask about stroke or mini stroke. You didn't ask about heart attack or autonomic neuropathy. You have asked about
Leg
the
pain.
sorry.
Leg pains are for peripheral arterial disease.
Okay, you mean disc prolapse?
No, no, sir. Like
Leg
complications
pain.
of
Yeah,
diabetes.
yeah, yeah, yeah.
Yeah, leg pain.
Claudication, leg pain.
Claudication. Claudication.
Yes,
Yeah.
gastropathy. All this you have to ask it in the systemic review. That's why I prefer to ask the systemic review after taking the constitutional symptoms and asking about the past medical history. Whenever you have diabetes, now you can ask the question of diabetes in the systemic review. So you will look organized and you will ask the question while taking system by system. The CNS, you will ask about all the CNS manifestation plus stroke or mini stroke. In the chest pain, any chest pain, and you can ask about chest pain or the heart attack,
I
any
see.
tummy pain or tummy distension or difficulty to tolerate the food, right? Any
Okay.
bowel motion change for diarrhea or autonomic neuropathy, I mean, and the impotence. The best way is to ask, do you have any change in your intimacy?
Okay.
Okay.
Yeah, I think it's good to ask about the past medical history, then to ask about the systematic review.
Yes, this is what my favorite approach. I will share it with you after the session,
Thank
so you
you.
will see how you will be organized. You will take the complaint analysis, then the relevant system, then the constitution symptoms, then the past medical or surgical or allergy or whatever in the history of medical part, then the systemic review. Then during the systemic review, you are organized and you are targeted question to the system you might have affection in it. Like
Mm-hmm.
in our system today, the all system will be affected So you can ask every question in every system accordingly. Even the genitourinary, if you want to ask about the urine, you can ask about the frothiness, right? So this is, but in reality, this case today was hypothyroidism. What you missed in the question to miss the case, as Dr. Minam said, the weight gain. Where is the weight gain as approach or a question in the approach? The weight gain. What do
I
you think?
think I asked about fever, night sweats, lumps or bumps, but I forgot to ask about the weight. Yes.
It's a package, Dr. Inas. The question of the constitution symptoms, you ask them together. Any change on the weight, any change in the appetite, any lumps or bumps, night sweat, night body or high body temperature.
Okay.
All of them together.
Sure.
Okay. Whenever you ask one of them, ask the others. Plus, anyone told you are paler, anyone told you your eye like yellow, or any itchiness. This is for the liver. Any dizziness while standing from sitting position. All of them you can consider as constitutional symptoms, but the most important is the weight and the appetite. Why? You might have a change, like in our case today. You might have a change in the weight, increase weight, and the case will be deviated totally about
Yeah.
the scenario. Agreed?
Yes.
Yeah. Okay. Otherwise, you did good examination. But if you miss the most important part, which is the hypothyroidism, you will miss the case.
Yeah,
You give a
okay.
differential of hyperglycemia, peripheral neuropathy, but the case was carpal tunnel. So please focus, focus, and focus. Take the history in this way. Hopefully, you will not miss any of these findings. Okay, I will share with you the approach. I think I shared it with you before or not.
Um.
Okay, I will share it again.
Thank
So
you.
this is the best way to take history. It's organized, simple. Please, if you follow it, believe me, you will not forget anything. You will not miss anything.
I will.
And
Thank you very much.
unless you have approach, whatever you are following. But I believe the most important thing you have to start with is the constitutional, followed by past medical history. Okay.
So after the history presenting illness, ask about the constitutional symptoms,
Exactly.
then the past medical history,
Exactly. Then
then
systemic
do the
review.
systematic review.
Yes. This is the way. Okay.
Fantastic. Yeah.
You have any question?
No, I think that was really good for me. Thank you very, very much. I learned.
Okay. Let's go to the management of carpal tunnel because we didn't talk about it.
Okay. Okay. So carpal tunnel syndrome. I would divide it to conservative management, medical management, and surgical management. Conservative management, teaching the patient about the disease and what are the factors that might trigger this. Medical management would include neuropathic pain medications like gabapentin or pregabalin or duloxetine. And surgical management includes there is a surgical intervention for carpal tunnel. I cannot remember what is it called, but it's basically they release the pressure.
Exactly. Decompressive surgery.
Yeah, decompressive surgery.
Okay. Sometimes also they can inject.
Corticosteroid.
Yes, topical steroid.
Okay.
Okay.
Yeah, and it's
Yeah.
very important to treat the underlying
Yes.
cause.
What do you think?
So for this patient, if the patient is hypothyroidism, we need to top up their thyroid medication, thyroxine, and recheck the thyroid hormones afterward, just to up titrate or down titrate the medication as needed. And I think the
Don't
surgery
forget
is,
the multidisciplinary team.
of course, yes.
Okay. What are the team here you will call?
So, because the problem is endocrine, we need to involve the endocrinologist and the endocrine nurse to manage the endocrine bit. We need to involve the neurologist and the physiotherapist and occupational health support worker. A physiotherapist would be able to help the patient to do exercises to enhance the strength of his hands and diminish or decrease the chances of disuse and improve the patient's quality of life. And it's very important to get the occupational health support worker assessing the house condition, the
Okay.
work and transportation, and to facilitate equipment that might
Do you
help.
think the dietitian is important here?
I think it's very important if the patient
Yeah.
gained weight.
Yeah. Yes, it's very important to reduce the weight. Okay. Including the dietitian referral.
Yes,
Okay. Again, well done, but focus during taking the history.
I will.
Yeah, try to analyze it more to know
Okay.
what are the nature of the complaint exactly. Then follow the approach. Hopefully, you reach diagnosis.
Actually, my friend has had carpal tunnel last week in his short case in urology,
Mhm.
and he sold it as radiculopathy C6. But I think the whole of discussion was targeted towards carpal tunnel syndrome.
Yes, exactly. It's very important. It's not only as a carpal tunnel. It might come as rheumatoid arthritis, as I said. It might come as pregnancy complication. It might come as post or patient or renal dialysis.
I see. Fantastic.
Or
Thank you.
okay. Any weight gain can cause it. Acromegaly also can cause it.
Oh yes, acromegaly actually. Yeah.
So the weight gain itself can be the reason. Any cause of weight gain, it can be the reason. And you know the cause of weight gain, right?
Yeah. Yeah.
Okay. Any other question you have?
No, thank you very, very, very much. I really appreciate it.
Okay. Let's go back to the comments. Anyone has comments before reading the chat box message? And Dr. Ala. Yeah, this is a previous case. Okay, Dr. Ala, I think it's diabetic neuropathy mainly as lower limbs affecting symmetrically, not only carpal tunnel isolated case. Suppose really to have the nerve affection in the lateral part of the hands. If you have carpal tunnel, maybe it can be or it could be masked by the peripheral neuropathy, but it's unlucky patient to have both of them. However, I don't know if the peripheral neuropathy can cover the carpal tunnel or it will be there. As in this scenario, she said no dermatome affection, right? But supposed to have dermatomal affection if you have carpal tunnel. I mean the medial nerve distribution. Other differential is peripheral neuropathy due to hypothyroidism. Patient is known case. Yeah, he got it. Osteoarthritis, Dr. Minan, Parkinson, motor neuron disease, polyneuropathy, cervical myelopathy, bilateral radiculopathy. This is our top differential or as a complaint differential. Shaking of the hand, Dr. Minam, and gripping the hands, Dr. Al Shaima. But here the cause of presentation, the weakness or tremors. No, it wasn't tremors. It was weakness. Please, whenever you have weakness, know what is the type of weakness. Is it floppy one or stiffy one? Accordingly, you will differentiate between upper motor causes or lower motor causes. Here it's lower motor, of course, because carpal tunnel syndrome, one of the peripheral nerves affection, and the patient will be having floppy hands. But here the distribution of the pain is different because of the carpal tunnel. So you have to be more specific to ask about carpal tunnel. Carpal tunnel, please. It's a very important topic in PACES. You have to ask it specifically. Do you think the pain at the night more? Yes. Do you think the shaking can improve or relieve it? Yes, this is carpal tunnel, definitely. Okay. You have to know what are the cause of carpal tunnel after that. Please send the approach. Yes, of course. I will send it. Give me just a second to find it, then I will send it. There is also video about it. Short video about how to take history, but I will share the approach quickly. Give me a second, please. Then you can save it later on. Anyone has question? This is the approach, how to ask in the same steps in order. I send it to chat box. There is also a short video about it, how to start to analyze You can follow and you can find it in the video. I mean in the channel, in the YouTube channel of the group and mine. Any question before ending the session? Dr. Minam and Dr. Inas? Anyone has question?
Thank you very much.
Okay, most welcome. Anyone want to ask or to comment? Occasionally, we have hyperthyroidism today and hypothyroidism. By luck, no one, I think you didn't arrange together.
Look to the irony.
Yeah. But see the importance of both topics, either hyper or hypo. It's very important. Believe me, it comes in every diet. Yeah, this is also, thank you, Dr. Hida. This is the video for systemic review. There is a lot of shorts. It's not long, only maybe 2 or 3 minutes. You can hear them. How to take history, how to counsel, how to do the systemic review, how to analyze the complaint. Just approach in the YouTube channel, you will find all of them. Any other question? By the way, the YouTube channel in the description of the group, you can find it. And we are sharing every day the session. You can also approach through the video, the channel, I mean. Okay, thank you everyone for attending today. Yeah, Dr. Hida already shared the YouTube channel. Thank you, Dr. Hida.
Thank you.
Thank
Thank you very much, everyone.
Thank you, Dr. Nas and Dr. Minam. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.